Good morning, friends. It is my privilege today to welcome you all to the next COVID Pulse lecture from CMC Vellore. In the domain of science and medicine, without constant ongoing refreshing of knowledge, we will lose our relevance, and nowhere has it been more evident than in COVID care. I thank the CMC COVID Command Center Training Desk and Dr. Thomas Samuel Ram, Associate Director at CMC, for perseverance in the task in organizing this lecture series. Today, we have some great speakers, and our moderator is Dr. DJ Christopher, Professor of Pulmonary Medicine and himself an eminent teacher, clinician, and researcher. He will introduce the speakers to us and take us through the session. A request to all participants to keep their mics muted. Please post your queries on the chat box. We have people who will collate the queries and do the needful. Please let us be civil in all our interactions. Thank you very much. And over to Dr. DJ Christopher.
Yeah, good morning and welcome to you from Christian Medical College, Vellore. As we have all watched this happen, it's barely 3 months ago when we believed that we have got the pandemic behind us. We had the vaccines and we thought we have crossed this huge pestilence that came upon us, in fact, globally. But the second phase came upon us so suddenly and caught us so unprepared. To address important issues pertaining to the second phase, we have this webinar organized. This addresses irrational treatments and what should be avoided. We have 3 very eminent speakers who are going to give their perspective on these important topics. And I'm sure we have a great session ahead of us. And we have set apart time to address your questions. So please put in your questions on the chat box. We shall take up as many of them as possible. May I now start with the first speaker. The first speaker is Dr. Gagandeep Kang. She's an alumnus of Vellore, batch of 1981. She's a microbiologist and virologist. She's a fellow of the Royal Society and has several accolades to her credit. So I do not want to waste time going through all that, but since most of you know her. So she's going to talk about vaccine myths and facts. Over to you, Cherry.
Thank you, DJ. I need to just share my screen. Can you let me know if you can see my screen now?
Yes, ma'am.
Yes, we can.
Okay, thank you very much. I'm going to keep this short because once we get started or talking about misinformation and disinformation, there is actually no end to it. So let's start with 2 stories that I'm going to tell you. The first one came out in December of 2020, where there was a petition to the European Medicines Agency saying stop all COVID vaccine studies. This was specifically for the Pfizer-BioNTech vaccine. It came from somebody who sounded very, very credible. He was a former research scientist at Pfizer. And with him was Dr. Wolfgang Wodarg, who was a member of the European Parliament. So they asked the EMA to delay the study, and their concern was a protein called syncytin-1, which according to them shared a similar genetic sequence with part of the coronavirus spike. Now the spike obviously we know binds to the ACE2 receptor, and they said this syncytin protein is a part of the placenta in mammals. If the vaccine makes us make antibodies against syncytin, it's going to make the body attack the protein in the placenta and it'll make women infertile. So shown on this slide is a comparison of the protein sequences of the spike protein and this placental protein syncytin. The spike protein has 1,273 residues and The synctin protein has 538 residues. And what you see here is that a string of 4 residues is similar between synctin and the spike protein of SARS coronavirus type 2. Now, this sounds very worrying. But if we look at 2 proteins that are very common in the human body, hemoglobin and collagen, and you do exactly the same thing. You compare them to the spike protein. You can see that in hemoglobin that you have at least 4, maybe even 5 nucleotide bases that are similar in the hemoglobin at one site and another 5 at another site. So hemoglobin is even more similar to the spike protein than synctin protein. You do this for collagen, you find another string of similar proteins. You can do it for actin, you can do it for many proteins in the human body. But if you do this kind of analysis and you keep what you are analyzing very, very small, you will wind up with similarities. So when you look at the similarities, these are really too small for our immune system to be confused by the two. But even if we said that the immune system can be confused by 2 very similar proteins, well, the spike protein is part of the virus. So if we were going to see issues, we would have seen those issues in people who had gotten infected. And we are not seeing that. The women who are pregnant are delivering. They do have issues with preterm birth, but it's certainly not causing infertility to have a COVID-19 infection. Additionally, at Yale, scientists who were investigating the impact of maternal antiviral responses on fetal development evaluated sera from women with COVID-19 and found that the antibodies that they were making against the coronavirus had no activity against the synctin protein. So what sounds really worrying, when you actually start looking deeper into the facts, you find that it is not true. And this, looking at the credit, so important. Dr. Michael Yeadon, who complained about this synctin protein, also had previously said that there was no second wave of COVID-19 in the US. And we know that that was not fake news. That many people getting sick and dying is not fake news. But that doesn't stop anti-vaxxers. These kinds of warnings are still there on the internet. There is one from the 15th of March. Even though this happened in December, was discredited already in December and January, there are still sites like this Medical Kidnap that claim that whenever you take a vaccine, you're setting yourself up for losing a baby. We know that that is not true. It's much more likely to happen with infection than with vaccination. So making sure we have a responsibility to advise people correctly, to explain what the facts are, and explain why what sounds credible and scientific isn't really that at all. Now, there is another one, which is my second story, which is a guy called Geert van den Bosch, who has sent out a letter, made presentations talking about how it is completely wrong to vaccinate individuals during a pandemic. And he has made presentations at a meeting, the Vaccine Summit in Ohio in March. This has been widely circulated on social media. And he goes through a lot of rambling arguments. He has this presentation, he has letters, he has articles, Twitter feed, etc. So I thought I'll just walk you through some of the statements that he makes and what the facts really are. He claims that you shouldn't use a prophylactic vaccine in populations exposed to high infectious pressure. And he says it's a first principle taught in vaccinology. There isn't such a principle. In fact, it goes against what we do to respond to outbreaks. Polio, measles, Ebola, we get in there and we vaccinate everybody. He says that innate immunity is very important for vaccination. And he makes this sound really, really pseudo-scientific. He keeps talking about, people are, their precious variant, non-specific innate immunity will be gone because vaccinal antibodies outcompete natural antibodies for binding to COVID-19, even when their affinity for the viral variant is relatively low. This makes no sense. With vaccines, we don't worry about innate immunity, we worry about adaptive immunity. Vaccines, and he does talk about variants and escape, and yes, that is something we worry about, but we worry about whether our adaptive response can handle that or not. And we know that variants are neutralized less well when the antibodies have been generated in response to an older form of the virus. That's mainly in the lab, and we can measure that. But vaccines are actually working against the B117 or the P1 variant, and in the lab, we have data for the B1617 as well, showing that vaccines are likely to work. How well, that we will know only when the vaccines are in humans. But it isn't because they escape the innate response. He also has a lot of descriptions that no scientist can understand, but they actually sound very convincing to a lay audience. Natural asymptomatic carriers refers to subjects who don't develop any clinical symptoms or only mild symptoms. Well, asymptomatic by definition means no symptoms. And all the other things he says about antigen, non-specific killing via natural antibodies, he may be referring to natural IgM, but that is constitutively addressed. As long as there are B1, B2 cells, you will have that IgM being made. When we think about what actually shuts down immunity, he's got all his facts wrong. We believe that shutting down infection quickly is because of the rapid interferon response and not, as he claims, because of natural killer cells. In fact, a high NK cell response is associated with severe COVID-19 disease. So his facts are wrong, his descriptions are wrong, and his figures are wrong. So I've circled there something that he claims is very important, again, playing to natural killer cells and the fact that they are responsible for people developing severe disease. But this does not actually happen. In fact, it is a situation where if you have the presence of MHC class 1 proteins on a cell, that indicates to an NK cell that no viral infection is present, and it functions as an inhibitory signal. So what he's describing as a flow diagram is just not accurate. So in summary, he says vaccines are imperfect. If we use them in the context of a pandemic, they will allow the virus to be transmitted from person to person, that the virus will mutate inside us until we have a dangerous new variant that will come in. But actually, variants started emerging before vaccines were used. And when vaccines induce a neutralizing antibody response, all the vaccines we have now are inducing neutralizing antibodies at least as well as infection or better. We know that vaccines are preventing disease, and in recent data, we know that vaccines are decreasing transmission as well. So both in terms of the lab science he points out, the population science he points out, is completely inaccurate. So those are myths for which we have to identify the facts. But there is one fact where I would like to explain to you exactly what's going on, and that relates to clotting and thrombocytopenia. The AstraZeneca and Johnson & Johnson vaccines are associated with a rare side effect, which happens 4 to 20 days after the first dose. This is very specific. It is not every clot. It is thrombosis with thrombocytopenia and is associated with the presence of antibodies to platelet factor 4. The fact that we have been able to find it has been because we have really good pharmacovigilance in place. We also have a measure of how important this problem is. And I'm showing you here a comparison of the risk of blood clots with the AstraZeneca vaccine, with birth control, with smoking, and with COVID infections. This is a very rare side effect, and it has been stated as much by the UK regulatory agency. There are lots of other myths out there. Vaccines were rushed, vaccines were unsafe, they cause COVID-19, I will test positive, they have microchips in them, they will alter my DNA, they contain parts of aborted fetuses, they contain parts of animals, and none of these are true. Nor is it true that once we are vaccinated, we can do whatever we want. So I think, if you do a deeper dive into the data, we will find that many of the misinformation that is out there can be countered. And what we need to do is equip ourselves with the understanding and the tools to counter this. WHO has a guidance document for how to do this, assess the source, go beyond the headlines, look at who the person is who is stating these facts or so-called facts, check when it was put in, examine the supporting evidence, think about biases, and turn to fact-checking organizations. This basic checklist, I think, will be very helpful to us. So thank you very much for your attention.
Thank you, Cherry. I think you addressed most of the major objections, and you have done that very decisively. I can assure you there are a lot of questions queued up for you at the end of the talks. Thank you. We will move over to the next lecture, which is on irrational treatments and what should be avoided. Nothing can be more important today than this important question, since all kinds of drugs are used with impunity in our country, and many of the drugs are available over the counter. So there's nothing stopping people from using what they wish. So to bring that to us, it's Dr. Priya Sampath Kumar. She belongs to the batch of 1985. For some reason, I cannot recall her. She is now Associate Professor and Consultant Infectious Diseases Specialist at the Mayo Clinic, Rochester, Minnesota. Her research interests include the epidemiology and control of antibiotic-resistant organisms in the healthcare setting, healthcare-associated infections, new modalities of treatment of Staphylococcus aureus infections. You're very welcome, Priya, to this forum, and we look forward to your lecture. Over to you.
So I'm going to jump right into the topic because I have a lot of stuff to say about COVID-19 management. So as most of you are aware, COVID is sort of a 2 to 3 phase illness. In the early phase of the illness, you have virus replication. This is the pre-symptomatic and the early symptomatic stage where you have mild symptoms. The virus is actively replicating, attaching to ACE inhibitors, mainly in the lungs, but all over your respiratory mucosa. And many people recover fully after this stage. Some people, however, go on to a more severe host response where the host inflammatory response response is revved up and you now progress to severe hypoxia and even ARDS. So when you're thinking about management and treatment of COVID, you really need to think about what phase the patient is in and what modalities are most likely to be helpful. So in the early phase, if you start using steroids, virus replication is actually going to increase. In the later stage, if you try to use antiviral drugs, they're not likely to be very helpful. So I'd like you to kind of keep this image in your mind as I talk about what the treatments for COVID could be. So I've been working with folks at CMC and trying to come up with an easy to use guideline for management of COVID. There's a WHO guideline, there is the ICMR guidelines, and then there's the CMC guideline. And the CMC guideline is very much evidence-based, but it has some issues with just classification of patients, I think, in that it's, the highly trained CMC physicians can work through all of those nuances, but I created my own treatment guideline, which I'm showing you here, that can be easily adapted to be used in the field, in smaller hospitals, in mission hospitals. So this is adapted from the WHO guidelines, from the CMC guidelines, and also from the US guidelines put out by the Infectious Disease Society of America. So the first point I want to make is that in the current situation in India, if you have symptoms suggestive of COVID, so fever, unexplained fever, cough, shortness of breath, and especially if you have loss of smell and taste, you just have to assume this is COVID. And regardless of what your test results show, you should be assuming the patient has COVID and then moving on to assess them to decide which stage of the illness they're in. And when you're assessing severity of illness, the most important thing is how comfortably the patient is breathing and their oxygen saturation. The respiratory rate less than 24 and oxygen saturations that are greater than 90 generally indicate mild disease. And you really need to take both of these into account. I get a lot of phone calls currently from India from people who are frantic. And this afternoon, I actually had a phone call from somebody who was in a government hospital and really wanted to move their father to a different hospital because his oxygen saturation was 70. They had found an oxygen cylinder and a taxi cab to take him to CMC Vellore, which did not have beds. And I was trying to calm them down and talk to them about how the patient was actually doing, and he was texting them. So with a oxygen saturation of 70%, I don't think he would have been texting with his family if that was true. So there are a lot of pulse oximeters that aren't reading quite correctly. So don't just go by oxygen saturation, also take the patient's clinical status into account. If someone is breathing very comfortably, is awake and alert, it's unlikely that their oxygen saturations are dangerously low. So since hospitals are so full right now, in this early stage of the disease, when patients are not hypoxic, it's very important that you reassure patients, that you tell them to stay home, not go out and infect other people, that they wear a mask, and that they continue to monitor oxygen saturations and their clinical status. The only medication that really they need is something like paracetamol if they are having a headache, if they're having a fever. There is some data that shows that budesonide, which is a steroid inhaler, may have a role. The role is very small, and I'll talk about it in a little bit more detail in a few minutes. But the key thing to remember is that at this stage, dexamethasone is not helpful and can actually be harmful. The next stage of COVID, if these patients progress to either become more tachypnic or to have low oxygen saturations, in an ideal world, these patients should be admitted to the hospital. But right now, I know that hospital beds are very, very tight, and you may have to manage some of these patients at home. So what do you tell them at this point? Again, you tell them to continue to monitor oxygen saturations. You tell them to prone themselves. This is actually so incredibly effective, and many people don't realize that this can actually be life-saving. So the theory of why this works is that when patients are prone, air entry into the posterior part of their lungs is greater, and you get better oxygenation. If you are in a hospital or if you're in a place where you could get lab tests, then you just need basic labs, CBC, CRP, and D-dimer. If you're not able to get any labs, you're probably okay without doing any lab work at all. If the patient is at home, or even if they're in the hospital and they're immobile, rather than using injectable heparin, either low molecular weight or standard heparin, I think that using something like Eliquis, apixaban, twice a day orally will ease the stress on the medical system. Patients can take it themselves, and it protects against DVT as well as low molecular weight heparin or other agents, and is easier to do. And this is definitely an option if the patient is at home. And then titrate oxygen just to keep the oxygen levels around 92%. This is also important in a time when there's a huge oxygen shortages, that you not try to aim for an oxygen saturation of 100%. Somewhere around 92% is more than adequate. And some of these patients, as I said, probably somewhere around 5% of patients will progress to more severe respiratory illness. And that's usually marked by dropping saturations and worsening tachypnea. Again, in an ideal world, these patients should be admitted to an ICU. And many times I know that even in CMC, many of these patients are being handled in the ward. And the important thing, again, is continue to continue to provide anticoagulation. And at this point in time, as the hypoxia progresses, you should be starting a dexamethasone. And the dose that is recommended is 6 milligrams once a day for 5 days. And there are a lot of alternatives. I know there are shortages, so I've listed out the equivalents of 6 milligrams of dexamethasone on the slide. And again, dexamethasone in this situation can be life-saving. There is very limited role for other therapies in these patients, and one of the agents that is helpful is tocilizumab. Now, tocilizumab is in very, very short supply. Again, if used correctly, less than 0.1% of patients will likely benefit from tocilizumab. And those patients are the patients who have improved somewhat with steroids and then taken a turn for the worse. And if you're going to use tocilizumab, it really needs to be used within the first 24 hours of the acute respiratory deterioration. Now, if you don't have tocilizumab, I understand the tocilizumab has sort of been commandeered by the government. So if you don't have access to tocilizumab, something that we use at Mayo, provided the patient it does not have diabetes, is actually dexamethasone at a higher dose. So we go up to 20 milligrams daily and treat them for 5 days with the 20 milligram dose, and then go down to 10 milligrams for 5 days. So this is kind of, the poor man's tocilizumab, giving them higher doses of dexamethasone. And I do want to caution you that if you're doing this, you do need to follow blood sugars. I'm hearing a lot about Mucor cases in India, and this is because of use of steroids for longer periods than are recommended and at higher doses than are recommended. And if you follow blood sugars, use the right doses of steroids, I think the Bucor cases can probably be prevented for the most part. So I wanted to talk a little bit about the role of steroids in COVID. This is dexamethasone in particular is one drug that actually has shown a mortality benefit. So there have been a number of different meta-analyses, which I've listed on the slide that I won't read out to you, that actually showed a 28-day mortality benefit. And in these meta-analyses, the largest single study that showed benefit of steroids was the recovery trial, and they included patients with both confirmed and suspected COVID-19, and they excluded excluded patients who had contraindications to dexamethasone. So those were primarily people with uncontrolled blood sugars. And as you can see, that there was a 3% absolute reduction in mortality. And this was actually even more significant. The mortality benefit was actually higher in patients who were already on a ventilator or receiving ECMO. And there was a subgroup analysis in patients who were not on oxygen. And in these patients, there was a trend towards higher mortality, although this was not statistically significant. So the next thing that, in my algorithm, I didn't have remdesivir listed at all, but I'm sure you all have questions about what the role of remdesivir is. As you all know, remdesivir is an antiviral drug. It therefore only works in the early stage of illness. It was initially tried, was approved for use for Ebola. And then when COVID started, there were a number of trials in the United States and in other parts of the world that looked at whether or not remdesivir would be of benefit. And there were very, very high hopes for this drug. And the biggest trial of remdesivir was the Solidarity trial. And disappointingly, there was no difference in 28-day mortality. Now, remdesivir is an expensive drug. So, of course, there was a lot of interest in trying to find some reason to use it. And so there was another trial called the ACT-1 trial. This was a multi-country randomized control trial. And they published their results in the NEJM, and they showed that there was faster time to recovery. And you could see that the median recovery in patients who got remdesivir was 10 days versus 15 days with placebo. And this benefit was seen only in patients who were already getting low flow oxygen at baseline. And there was absolutely no benefit in patients who were already on a ventilator or receiving ECMO. Now, this needs to be really taken in the context of India. So in addition to the faster time to recovery, there was also reduced viral loads in these patients. But this benefit is so very small, and nobody in India who is on low flow oxygen is actually staying in the hospital for 10 days or 15 days. So these results really were obtained early in the pandemic when we were keeping everyone in the hospital for several days because we were worried about the course of the illness. We didn't know how these patients would behave. We were worried about blood clots, etc. In India right now, when it's so hard to even get a bed for mild illness, I think that remdesivir really has absolutely no role in the treatment of COVID. So then we talked about tocilizumab, and I want to take a little time to talk about the indications and what you need to watch out for if you do use tocilizumab. So as you know, tocilizumab is a monoclonal antibody to IL-6. It significantly reduces systemic inflammation. And so it's a drug that has been used in the treatment of rheumatoid arthritis primarily. It also has been used more recently to treat the cytokine release syndrome after CAR-T. So these patients have a highly revved up immune system, and the tocilizumab can be life-saving in these patients. Through extension, because it appeared that a lot of COVID patients had a similar cytokine storm, there was interest in trying this drug for treatment of the cytokine storm in COVID. And I'll talk about the trials in a minute, but one thing you do need to remember is that because tocilizumab is so highly immunosuppressive, there is a risk of serious infections, especially in older individuals and those who have other comorbidities. And in India, with a high rate of TB, this drug really should be used very, very cautiously. Even in the US, we have been seeing patients have secondary bacterial pneumonia, cellulitis, sepsis after treatment with tocilizumab. And the other thing that happens is reactivation of mycobacterial infections, pneumocystis infections, and also shingles. So what is the role of tocilizumab and other IL-6 inhibitors? There have been several trials that looked at this, and the largest trial was in the UK, which was an open label trial. And they enrolled patients with COVID-19 and hypoxia and evidence of severe inflammation as measured by a CRP level of greater than 75. And they gave either 1 or 2 doses of weight-based toci. The dose given was 8 milligrams per kilogram, and they compared it to usual care. And there was a mortality benefit in these patients, with mortality in the toci arm being 31% versus 35% in the standard care. And there was also a suggestion in the trial that the progression to mechanical ventilation in patients who were on non-invasive ventilation, the progression was halted. So, and then in the subgroup analysis, really the patients who benefited the most from toci were those who had had some initial improvement on steroids. So if steroids are not working and the patient did not have any benefit at all from steroids, then these patients are unlikely to benefit from tocilizumab either. There was another trial that used either tocilizumab or another IL-6 inhibitor called sarilumab. And here again, there was a mortality benefit in severely ill patients. Now, there were several other small trials that did not show a mortality benefit. And the thinking is that these patients that the trials had various inclusion and exclusion criteria. And so if you don't choose your patient correctly, the tocilizumab is unlikely to be useful. And I've listed some of the studies for those of you who want to look up the details of these trials. So I'll just move on to the next drug that gets a lot of hype. And I just, all of you on Twitter, on Facebook have seen these frantic messages asking for plasma. And they typically say that the patient is in the hospital, is ill, is very young, is on a ventilator, and they desperately need plasma. So what is the role of plasma in these patients? So really, if somebody is desperately ill and in the ICU, there is no role for plasma at all. The first studies of convalescent plasma actually started at the Mayo Clinic, and a friend of mine initiated the trials. Remember, the trials began in March of 2020. At that time, there were no therapies at all that worked for COVID. Patients had a very high mortality in places like New York, and there was a lot of interest in using existing therapies, modifying them, and seeing whether they would work for COVID. Convalescent plasma has a long history. As you all know, we use it for treatment of prophylaxis of rabies. We use it for treatment of tetanus. So this using antibodies has a long history of being effective in various types of infections. So this got a lot of hype, and very quickly we were able to enroll very large numbers of patients. The first trial accrued about 30,000 patients in the plasma treatment studies within about 3 or 4 months. And the results were really mixed initially. And part of the reason was that we did not have good ways to measure the antibody titers in plasma. So one thing that has emerged with use of convalescent plasma is that if you use low titer plasma, it has no benefit at all. The only benefit is from high titer convalescent plasma. So you need to have the ability to check neutralizing antibodies. The convalescent plasma is not useful at all in severe disease. So again, it works, the antibodies, if you think about it, act against the virus. So it only works in the early phase of the disease while the virus is still replicating and you have not set off the whole inflammation cascade. So if you're using it, it should be used early in patients with mild disease, and it may have a niche role in patients who are on B-cell depleting therapy where they cannot make their own antibodies. Now, there is some concern with use of plasma and also monoclonal antibodies with these new variants because it's possible that these variants may escape from antibodies that were produced in response to a prior strain of infection. So there still needs to be a little bit more information gathered on whether this has a role at all in India. So in my algorithm, I did talk about a steroid inhaler called budesonide. And this is data that has just come out very recently and is still actually in preprint form. And one reason I put it in the guideline is because this is relatively inexpensive, and patients want something. If you tell them to stay home and just take paracetamol, they're unhappy and they feel they're not getting any treatment, and they're worried about progression. So this is one treatment that, at least in one study, a randomized controlled study, has shown some benefit. Again, the benefit was in time to recovery. Not in mortality, although it did show a slight mortality benefit, although the numbers were very small. You can see that in the last bullet point, 8.5% of 692 patients versus 10.3 in the usual care group. The budesonide is relatively easy to use for young people, and it does help cough, but really, because there's such a short supply, and because in the trial it was studied only in older individuals, either those over the age of 65 or those over the age of 50 with some comorbidities, that's the group in which it should be used. And probably not in everybody with COVID. And I'm hearing from people in India that this is already very, very hard to find, because people are rushing out and it's flying off the shelves. So I've had questions from a number of people from CMC actually about the role of another new agent called baricitinib. So all of these are repurposed drugs. This is a drug that is used for the treatment of rheumatoid arthritis. And again, it's an immunomodulatory agent, and it may also have some mild antiviral effects. And this has been approved recently in the US. As with an emergency use authorization. Now, the drug was only studied in combination with remdesivir, so we don't know whether it has a role by itself without the use of remdesivir. And again, this did not show a mortality benefit, just showed a reduced time to recovery. And I think this has almost no role at all in the Indian setting. In the US, we use it in patients who are unable to tolerate steroids. So if they've had a severe delirium with steroids in the past, or some other reason why they cannot take steroids, there may be a role for this. But in almost all patients, steroids have a much more robust effect than this drug, and should be the drug that you use when you have moderate to severe COVID. So I classified all these medications that we talked about into 4 categories. As you know, many of these agents appear in the AIMS ICMR guidance as things that you can use. And I really think, though, that the life-saving things in COVID are oxygen therapy, steroids used judiciously, and proning. Things that may be useful in certain settings would be tocilizumab, remdesivir, plasma, or monoclonal antibodies that I didn't really talk about very much, baricitinib and budesonide. Things that are not useful at all, but at least are not harmful, are vitamins and zinc. And then there are a whole host of agents that do have side effects, and really we shouldn't be using. And as you can see, I put steroids and tocilizumab infliximab again in this column, because if you don't use them correctly and you don't use them in the right doses, and if you don't use them at the right time, they can be harmful. And then everything else in this category, ivermectin, hydroxychloroquine, HIV medications, influenza medications, other types of immunomodulatory agents, azithromycin, doxycycline, fluvoxamine, all of them have not been shown to be helpful at all. And especially when used in patients along with other medications, you can have drug interactions and significant harm caused to the patient. So I just want to reiterate again what I said earlier. Assess your patients when they come in with COVID, classify them into whether they're mild, moderate, or severe. The mild can stay home. Moderate should be admitted to the hospital if there are beds. Otherwise, they can be managed at home with oxygen therapy and proning, anticoagulation, and steroids if they're hypoxic. The others, again, admit to the ICU if possible, follow oxygen saturations, give anticoagulation, apixaban, dexamethasone, and follow them. One thing that you will note here is that I really don't think there is a role for lab tests like IL-6. They have not been shown to be useful. And I also do not recommend getting CT scans or even chest x-rays routinely. If patients you think have something else going on, you should get a chest x-ray, including perhaps a chest x-ray to rule out TB. But getting CT scans, getting high-res CT scans, and repeating them throughout the course of the illness is not helpful at all. I have been working with an organization called India COVID SOS, and one of the first things we did was actually put together this infographic just to tell people that they can, that many of them can stay home. And as you can see, this is version 5. We went from version 1 to version 5 in about 5 days. And since then, we have some stability, and we're working on our version 6. And I think one of the things that will come out in version 6 will be the inhaled budesonide, because I don't think that it's really that helpful, and at least not for all patients. So this India COVID SOS has this tip sheet in English. The other thing that is very helpful is translations of this infographic into, we're up to about 18 Indian languages. So if you have people that would benefit from it, please feel free to go in, take a look at it, and download any of the infographics that you find useful. In addition, because of this dearth of really clear guidelines on management of COVID, some of my colleagues and I actually created this website and are hosting clinical management guidelines here. And one of the other things we're also doing is helping you triage patients in situations where you don't have a pulse oximeter. We're working on guidelines for sort of the field hospital setting, where you need to quickly triage patients and decide which ones can go home right away, which ones actually need to be admitted to the hospital. So I have just one more slide to show you. And maybe it didn't make it into my presentation. I'll just stop here and open up after Rajiv's talk. I'll be happy to answer questions.
Thank you, Priya. So you covered almost all the important and contentious areas of treatment. So again, I'm sure there are a lot of questions waiting for you at the end of the session. Okay, so let's move on to the next lecture. This is going to be given by Dr. Rajiv Jayadevan. Now, Rajiv Jayadevan is a gastroenterologist. He was an undergraduate in CMC Vellore in the year 1986. After that, he was postgraduate, then went on to do gastroenterology training, and he has actually several excellent academic accomplishments over several years. He has trained in United Kingdom, has trained in US and worked there. and finally has come back to his homeland and is now practicing in Ernakulam. Above all this, I think he was my postgraduate and one of my favorite ones. And I'm meeting him after a long time. It has been a pleasure to meet him and have him here with us. He is now, apart from practicing medicine, also an author, public educator, scientific advisor, and past president of Indian Medical Association. He is going to talk to us about a very important aspect of this pandemic, which is science communication in the pandemic. And this is the era of social media, and they are the default providers of information. So Rajiv, over to you. Tell us what you have to say.
Let me start the story of Jackie the dog and the train. We know that in India, dogs love to stay in train stations or railway stations, as we call them. Now, Jackie the dog was so smart that she lived in a small town railway station. She used to get annoyed when trains would pull into the station because they blocked her view. Jackie discovered that if she barked at the train would start moving and go away, clearing her view. Jackie believed that it was her barking that made the train go away. Jackie presented her findings at the local doggy conference, and the other dogs refused to believe her. They said, "How can it be?" So Jackie said, "Try it yourself." So these dogs went back to their respective railway stations. They barked in the train and they found that the trains actually moved. So they all believed that it is their barking that made the train move. So then this went on for a few months until Julie, the wise old dog, came to the town and she questioned their findings. She said, "This is nonsense. You guys are all wrong." Then the dogs protested. "Look, we know it works. Why are you questioning us?" Julie said, "Try not barking for a change." So dogs obeyed Julie, and they found that even if they did not bark, the train would move just as they did when they barked. Correlation is not causation. Now, if you don't remember anything else from my talk, remember this. Just because two events occur at the same time, seemingly related, one need not cause the other. The human mind is so gullible that you just have to go to any magic show to discover how gullible our minds are. Magic works only because we are gullible. In the context of the pandemic, this dog story is so profound because COVID-19 has a very high spontaneous cure rate, which means that even if you do nothing, 80% of the patients will get better. It is therefore easy to be fooled about treatments that seem to work. Polypharmacy, unfortunately, is rampant. I have blocked the picture of a prescription by a doctor in India for privacy reasons, and this patient with mild symptoms got 13 medications and an order for a HRCT scan. This patient had mild COVID. There is one antiviral, and Priya would be furious to see number 2 and number 3 because she advocates rational antibiotic use. Because if you use antibiotics in the wrong context, you're going to make the patient worse, and it's terrible for the community. You're going to promote antibiotic resistance. Ivermectin, steroid, acibrophilin, you name it. I know the talk is constrained with time, so I can say I can cross out 13 out of the 14 because there is no evidence that any of these things will work. And as Priya said, some of these can be harmful. So I will just say number 13 is good. If the patient has a fever, yes, some paracetamol, plenty of fluids, and plenty of sleep. Here's another prescription written by a very enterprising doctor, again from India. This doctor has created another list, again, the magic number 13 medications for COVID-19. For what? So none of these things are effective or needed, and some of them can be dangerous. I represent also the Indian Medical Association. I'm an office bearer, and this is a letter from the IMA that says rational prescription is part of medical ethics that all doctors are bound to follow. The role of doctors has been changing in the pandemic. Now, just a collage of things that a doctor would do. We treat our patients, we read, we have to read a little bit more in the pandemic. And the pandemic itself is a collage of around 15 medical topics, including medical ethics, pharmacology, epidemiology, immunology, genetics, virology, critical care medicine, pulmonology, hematology. And we need to know a little bit of culture. Communication is the most important, in my opinion. You see the bottom, it's communication. And if you see the pyramid, the flow of scientific knowledge. Doctors know a lot of science, but the question is it reaching the policymakers? Is it reaching the media? And more importantly, is it actually reaching who it is supposed to reach? It's okay for doctors to discuss big things in their closed forums, but what we must ask ourselves as doctors is how much of factual knowledge is reaching the general public, and also are we also communicating wrong information based on biased knowledge? If for some reason this flow is blocked, guess who will fill the gap? This gap will be filled by fraudsters that Dr. Kang has very elegantly described. She took a lot of time to describe how certain fraudsters are creating such misinformation or disinformation that is confusing everybody. Fraudsters are better than most doctors because they have excellent communication skills. They can communicate better than anyone that you can imagine. They can make you believe anything. Now, they prey on certain buttons that we have, and those buttons are emotion, anger, fear, and the hope for a miracle cure. But I'll take a little bit of time to go through the neurology of these two phenomena. I would like to emphasize that science and belief are completely different entities. And what you believe is primarily related to what's going on in the limbic system, which is involuntary, it's connected with emotion and very abstract. It's considered to be the primitive part of the brain, whereas the frontal lobe, which is what makes us the science-based progressive society, is mostly called the neocortex, and I've labeled that in green. So science is green in the frontal lobe, and belief is blue in the limbic system. The two are different. This is the fundamental reason why doctors have difficulty in reaching across to certain people who have fixed beliefs. They say that a lie can travel halfway around the world, while truth is putting on its shoes. And while communicating, here are some challenges that we face as doctors. Firstly, the most favorable opinion. See, the public always goes for the most favorable opinion. If somebody says masks are useless, the public would be inclined to follow them. If somebody says vaccines are dangerous, the public would say, yeah, great, I don't need to get my shot, and so on. And then in India, we saw the disaster that happened with what is called the Indians are different. You know, when we started working on the pandemic, before it hit the country, some of us were called insane because they thought India was completely different. They felt that even doctors in our community felt that Indians are completely immune from diseases like viral diseases. I got personal calls from prominent physicians saying I was completely wrong in assuming that the pandemic would even come to India. Now that is the level of the rhetoric, and Indians are different doesn't work. We are no different. We are the same species. We have the same biology. And then I see what is called the in my experience attitude. You see, what is your experience worth? If you've treated 10 patients, is that worth a randomized controlled trial that painstakingly looked at 400 patients or 1,000 patients in each arm? It is not. So we have to get over our cockiness and say this in my experience does not work in science. And then I hear the no harm giving it excuse. This is an exclusively Indian mentality. What's the harm in giving it? Excuse me. have you monitored these patients after giving that medication? No. The patient walks in the door, spends 2 minutes in your clinic, and walks away with a prescription of 13 pills. Have you monitored this patient? No, you might never see the patient ever again. So how do you know there is no harm in giving it? So Priya is absolutely right in saying that some of these medicines that are commonly prescribed are harmful. How to reach out? There are so many mediums out there, and it's better to, like in investing, to have some diversification here, because not all people can be reached through all media. Now, while communicating, be prepared to get your feet wet. It's not an easy job. You will get some brickbats, and these are people who may get offended by your statements. They may mistake your statements for a political flavor. They may be anti-science people who are offended, or they may be just doctors who are offended that you oppose their favorite drug view. And they may be plain random people who have nothing better to do than to just argue on Facebook or on Twitter. So I'll explain to you how to communicate with these people, because I've been doing this for a long time. The first thing to remember is when you communicate on social media, texting has no tone. Now I teach communication. This is so important. So when you read text, you may attribute an emotion that was never meant, or a sentiment that was never meant. And it's very easy to go into angry discussions without knowing this fact. So how to face a heckler? My style, again, this is not evidence-based, this is personal experience. How I face a heckler. A heckler is someone who unnecessarily starts an argument for argument's sake. I give them one solid response, which is absolutely assertive. I don't hold back. Don't hold back. But at the same time, be courteous to the extent possible. And I always try to find a little bit of common ground. I explain why the original statement was correct. And I never get drawn into long discussions, no matter how tempting it is to go and argue against each point that this person makes, and never, ever respond to a name caller. So here is an example of how I responded to a heckler. On the left, you see, he says, what a stupid study, and so on. And he used some other, not so polite words. So in the middle is my response. You are welcome to discuss your views on my thread, but only if you promise to use civil language and show the courtesy to understand what the thread is about. Surprisingly, see the response? The person apologized. That's a gentleman. I use the Godfather's quote often. In social media, when you're faced with an unknown enemy, never hate your enemies, because if you get your emotions worked up, you will get drawn into an unnecessary discussion. If you don't hate your enemies, your response will be measured, accurate, and it will be widely read by others that follow you, and your stature will only be enhanced. Some hoaxes are best left alone. I don't have a lot of time to discuss this, but just to say that if you go after every fake news that comes, you may be amplifying them instead of suppressing them. So be very aware of what is called the paradoxical effect of battling every hoax that comes your way. Now, I'll take you in the latter half of my talk, I'll take you through some examples I use to communicate. There are people who believe that herd immunity is fine, and I don't want to take the vaccine because it's safer to get the virus, natural infection. I tell them this, very easy. You take 100,000 people with the vaccine, you take 100,000 people with the virus. In the first group, 1 person is hospitalized, 0 deaths from the vaccine. In the second group, 10,000 people get hospitalized and 1,500 die, depending on the age group. Now, this is plain as water. It is so clear that you don't have to explain it even further. And then there are people who take simplistic views on the immune system. I've been working on this so hard. I spent hours trying to read and understand the immune system. But people say, let's give an immunosuppressant. Or why don't you decrease your immunity? People who take simplistic views must see this. How I communicate with them is, the immune system is like the chessboard. If you try to play chess without knowing what each player, each chessman will do, you lose the game. So you try to mess with immunity with limited knowledge, you're going to create a bad outcome. So be very afraid, be very measured, be very careful about using immunomodulators that you know nothing about. So that's about immunology. Thomas wanted to post some of my notes. Thomas, this is for you. These are my notes on immunology. Again, I put it up here just to show. I scribbled my notes. Thank you. Whenever I add new knowledge, I add this as diagram. So I think virtually, pictorially. So this is my diagram. Again, to show people that immunology is not an easy subject. To the left is innate, to the innate immunity, and to the right is you will find adaptive immunity. All right. Simple ways to communicate. You see this woman is trying to show a smoke tube in a theater. You see the air is still in the theater. So you can easily catch an infection because the smoke just stays in the air. This visual is so powerful, you don't have to say any words to explain that in a closed space, you can pick up infection. These are some diagrams. Again, thanks to Thomas who wanted me to put up some diagrams. Again, to educate people that if you do this, and you pinch up the skin, you may end up injecting into the subcutaneous tissue. And very, very rarely, that needle could go into a small blood vessel. So here's a picture. You see that? You see how the skin is being pinched up. So the tip of the needle is nowhere in the muscle. See, this is a common mistake. So we need to get out there and educate people that this is wrong. And this is a new technology called Twitter Space that I used a couple of days ago. This is a diagram on Facebook. I used it in a Malayalam text. I used it for common man because the common man doesn't know what the lungs is. They don't understand what an alveolus is, and they don't understand what mucus layer is. So that green yucky thing is a mucus layer, and you can see it went up to around 750 shares, which is pretty big for my standards. And this diagram, all of you must have heard from me a million times. I didn't make this. This is a universal diagram for protecting yourself from any hazard. Forget the pandemic. So elimination, the lockdown that's happening, it's eliminating the source. The less number of people come to you with the virus, the better you are. So it is not just the mask you're wearing. It's not the PPE that's protecting you. Metaphors, I use them quite a bit to explain how vaccines work. For example, I tell them that COVID-19 is a wide range from 0 to 160 on a speedometer. 0 to 60 is your safe zone, and then your 60 to 180 or 160 is your danger zone. That's a severe COVID. So I tell them vaccines will erase the severe zone. You could still get COVID-19, but 0 to 60 is your safe COVID. So you know what? In 2 seconds, you can explain this to an audience who doesn't really understand a lot of science jargon. Here's a more complex explanation. A common question that all of us are going to get is, look, a lot of people are testing positive after vaccination. Does that mean vaccines don't work? Why don't we just stop vaccinating everybody? People are getting COVID anyway. How do you get to that? In people who don't understand immunology, you need to really talk in metaphors. Metaphors are basically examples that people can easily relate with. But using a wrong metaphor can create the opposite effect. So choose your metaphors very carefully. How I answer this question is as follows. Okay, you got a question. Somebody tests positive after vaccination. How do you explain that? I tell them, look, if you hold an umbrella in light rain, you won't get wet. You're safe. But if you hold the same umbrella in torrential rain, you will get a little bit wet. Likewise, vaccines protect against most cases, but some people still get sick. So does that mean you should stop using the umbrella? That's a good way to get across to people who may not understand T cells and B cells and innate immunity. This is a common graphic that I use, again, to show people that if you hang around with more people in a closed space for a longer time and you talk and sing without masks, you're going to infect everybody. And the opposite is true. A larger space, less people, shorter time, and less talking with mask on, it's good for you and good for everybody. All right. A problem with society in general is they believe anything that's printed. So with social media, everything is printed, so they think it's true. This is wrong. We need to educate people. We need to also educate people about what does not work. And Priya showed very clearly in her last slide what does not work. And you can also already see some defensive responses coming up in the chat box. Drugs like ivermectin have a cult following. They fall into what is called the belief chamber of the brain. People are emotionally attached to this drug and they believe it works. Once you believe it works, it's impossible to convince people it does not work. The same story with chloroquine. The makers of ivermectin, the people who created it have come out and said, hey, it doesn't work in this condition. All right. Modern medicine is ever changing. Let's be humble, because what makes modern medicine modern is the fact that we keep self-correcting. We look at what we look at what happened, a lot of things, what we believe now is probably wrong. And in the years to come, excuse me, it'll be proven wrong. And that's okay. That's what modern medicine is. Do not fall, dear doctors, into what is called a favorite drug trap. Never fall in love with any medication. Science has no emotion. Science is nothing but facts. Don't invest yourself into thinking that your own theory and your own drug is all that is the truth. All that glitters is not gold. And my last slide is, we may be watering our garden, but question is, are we reaching the roots? We may be communicating amongst ourselves in scientific forums, but is our communication reaching the roots, the grassroots level, the common man who needs our help? Thank you.
Thank you, Rajiv. I really am going to take back some of your tips in future and implement it. I think this is a terrific lecture with many practical tips. Thank you very much.
Thank you.
So now we have a lot of questions. Unfortunately, we are a little short of time. So what I will do is to ask you to respond in rapid fire mode so that we can cover as much as possible. Cherry, are you ready? There's a question about the use of oral contraceptives and risk giving vaccination. I assume it's in the context of thromboembolic complications.
Yeah. So DJ, I've actually answered all the vaccine related questions in the chat. So you can use the time for Priya and Rajiv.
Thank you, Cherry. That's kind of you. So those of you who have asked questions, please look up the chat box and get the answers. We have a lot of questions for others as well. The first one is about happy hypoxia. I don't think you touched upon that. Someone wants to know what it is.
Essentially, happy hypoxia refers to patients whose oxygen saturations are dropping and they are still comfortable. Most of the time when your oxygen levels drops by about 5% from your baseline, you experience sensation of dyspnea. Early on in COVID, we were seeing some patients come to the emergency room with oxygen saturations of 80, 78 without that sensation of dyspnea. And it seems to happen only in a minority of patients. And that's why we say, even if you're feeling comfortable, continue to check your oxygen saturations 3 to 4 times per day.
Yeah, thanks. There is a question about, prolonged fever. So most of our algorithms revolve around respiratory rates and saturation. So how do you handle a patient with fever exceeding 10 days? Do we do anything differently?
So especially during this second surge, I'm hearing about a lot of patients with fever that can last up to 2 weeks. Now, fever by itself is not particularly concerning if the patient's respiratory status is improving, if they're feeling comfortable. The one thing that you should evaluate is, could this patient now have a secondary infection, something else going on rather than COVID? But if the patient is clinically doing well and just has a fever up to 2 weeks, I think that's fine. The other thing that people ask is, well, what if yesterday the fever was 99, today it's 102, I need to rush to the hospital. So the temperature itself doesn't really matter. And I wish we would just tell people to stop checking temperatures. I don't think 99 or 102 or 104, other than in very young children, really makes a difference.
And there's questions on anticoagulation in those already on antiplatelet drugs. I'll combine this with another question on the role of aspirin post-discharge.
So I think you have to be very careful using dual therapy. So if somebody is already on an antiplatelet drug, unless you're able to monitor them carefully, you should not be adding another agent. So that antiplatelet drug itself should be protective against DVT. Sending patients home on aspirin, I don't think is necessary. provided the patient is ambulatory. So I had a lot of questions about duration of anticoagulation also. Remember, the anticoagulation is to prevent DVTs, and if the patient is actually well enough to go home and is able to walk around, you do not need to continue anticoagulation in those people unless they had a DVT while they were in the hospital.
So there's a question that is proning helpful for those with mild disease all the way through to those in the critical care? I think there's almost answered. But
yeah, very much so. Yes, both mild disease to severe disease, even in ICU patients on a ventilator, proning can be remarkably effective at improving oxygen saturation, as you probably have experienced already.
Yeah, DJ, can I just add to that? Just last night, we released a short infographic on proning, because a lot of our patients are now stuck at home because they can't get a hospital. A 3-paragraph infographic in local language with some pictures that was sent out last night. Because we meet every week, all of our doctors here, we meet every week and we discuss what's happening again on proning. Back to you, Priya.
On the chat box, if someone is interested, they can, take that. Okay, and another question, well, people here are very fond of favipiravir for early disease. So I'm going to club 2 questions again. There's also a new drug, 2-deoxy-D-glucose, developed by DRDO. It's only days old, this news came up. So do you think this will work, the second drug I mean, and what's your view on favipiravir?
So favipiravir has been studied. There's a preprint somewhere on its use in severe disease and no benefit at all. It's being studied currently for mild disease. And again, there's no data showing that it's useful. So it really should not be used outside of a trial setting. The 2D something drug, I've only seen it in the news media. I've not seen any published literature on it. So I really can't comment on it. Again, probably no evidence, but somebody, people are desperate for cures. And so I think this is another one of those that we need to study and not assume that it will work. And also, like Rajiv said, not assume that it won't cause harm.
Yeah, the 2DG has been used there's very little medical use documented. It was supposed to help in some cancer treatments because it blocked glycolysis, because cancer cells love to get their energy through glycolysis through a competitive inhibition of one of these enzymes. But they found that it really wasn't really doing much to trigger apoptosis. So I don't really understand the context of this becoming an antiviral overnight. There is really no published data on this, and I'd be very cautious about using anything that does not have published evidence.
Priya, maybe the last question. I'll club 2 again in the interest of time. Role of vitamin D. And the next one is do you use CRP for treatment decisions?
The role of vitamin D, there have been a lot of studies, very mixed data and I think that there's no conclusive evidence that it works. I just want to quote something that I got in WhatsApp. So they said if in today's world, if you have COVID, you simultaneously get treated for scurvy with vitamin C, zinc deficiency, vitamin D deficiency, scabies, malaria, rheumatoid arthritis, everything but COVID. So all of this polypharmacy, there's really no role. And then there was another question that you had, I'm sorry.
Use of CRP in making treatment decisions.
So the CRP can be helpful in just trending inflammation. So if a patient is doing well, I don't think you need to follow it at all. If a patient is not doing well, generally hypoxia is enough to guide your next therapy. So I don't think it's an essential test. It can be helpful to reassure you that nothing bad is happening, but it's a non-specific inflammatory marker. Same thing with D-dimer. We really don't don't trend D-dimer because we found that it can go up in sepsis, it can go up in a lot of other things other than thrombosis. So none of these tests are essential. They're just nice to haves. And I always tell the residents and fellows I work with, anytime you order a test, you need to know what you're going to do with that test result. So just ordering it and then figuring out how you're going to use it is not the best use of resources.
Thank you, Priya. Now over to Rajiv. Rajiv, I think there are questions about the role of nutraceuticals, multivitamins, vitamin C, D, etc., in the context of prophylactic treatment. So maybe you should take this up in the context of communication.
Yeah, we'll do that. Yeah. Very briefly, nutraceuticals are a huge multi-billion-dollar industry. Don't underestimate their industry. Their annual turnover is more than the GDP of several nations put together. It's a huge industry. So when there's a pandemic, there's plenty of people who will be interested in selling their own product. While I can't call that wrong in the strictest sense, if you ask me, is there any evidence that they will work? There's really no evidence that any of them will work. With the only exception of vitamin D, with a very strict clause, if someone is deficient in it, and the doctor believes that a therapeutic intervention is necessary for the deficiency. Remember that many people have a slightly low level. That doesn't mean that you should be treated. So now that has very little to do with COVID-19 in general, but that is perhaps the only indication where you would actually give a vitamin. Now, in someone who's malnourished and bedridden and is not eating well, yes, they may have to take some vitamins. But for the average person who eats a regular diet, there is no role in taking any vitamin. And as far as zinc, there's plenty of evidence it doesn't work. But you saw some of the slides again, Priya, I got some forwards about how some zinc products were hitting extremely high sales during the pandemic. And it's unfortunate, that it's unreal that people believe that these things work. So with every prescription, if zinc is written, I can't agree with that. So because it's not evidence-based.
Then maybe the last question, how do we deal with post-COVID symptoms? And perhaps have you tried communicating to people about post-COVID? And do you have a nice model?
Yeah. So post-COVID, as you know, is a group of people that who continue to have lingering symptoms even after recovering from this viral illness, and they tend to be younger. It's slightly more common among women, and their symptoms can range from heartburn to fire in the chest to difficulty focusing, what they call brain fog, to body aches, to headaches. Their exercise capacity comes down. So it's a mixed bag. So you could classify them as from organ damage, which is overt, for example, from pulmonary fibrosis that eventually will recover. And then there may be people with diffuse post-viral symptoms, something like the fibromyalgia symptoms that we see in medical practice, even otherwise. But the good news is, most of them recover, and there's good chance of recovery at the end of around 3 months if you follow them up. There is also interesting evidence accumulating anecdotally that many of them, their symptoms magically vanish when they get vaccinated with even a single dose of vaccination, about 40% by anecdotal reports from fairly credible sources. So that's an area where we should really look to see whether the innate immunity is kicking in, whether it's chewing up all the remaining bits of the virus. Now that is going into the speculation range, so I don't want to speculate, and I never do. Bottom line is there's an observation that they do get better with vaccination. So overall, post-COVID, they do well. They just need a bit of support. Doctors need to listen to them and don't blow them away thinking it's all in your head. No, when someone comes to you with a problem, patients don't come to hospital for fun, and there is suffering to be seen and to be understood, and the doctor needs to listen.
Thank you, Rajiv. There's one more question which I can take up. This is on the role of nintedanib in COVID patients. Now, in the last few months, there have been several prescriptions with pirfenidone and nintedanib, which are antifibrotic drugs used for fibrosing lung disease, interstitial fibrosing lung disease. And there is proof in certain groups of them that they're effective. But that has been extrapolated and being used to prevent fibrosis. So there are trials undergoing which is appropriate, but using them for patient care at this point in time is premature and perhaps not advised.
I'm glad you said
I think
that, because you're the person among the three of us, you're the king in that field, and if you say that, that is very important.
Thank you, Rajiv. So I think with that, it's time to draw to close this very exciting session with excellent lectures from three people who are extremely busy, but who are, well accomplished in their fields of expertise. And they amply justified that in the way they delivered their message. So I want to thank Dr. Gagandeep Kang, Dr. Priya Sampath Kumar, and Rajiv Jayadevan for coming and participating in this and surely benefiting more than 1,000 people. So thank you once again. And to the people that have logged in and are watching this, well, thanks for your patience and thanks for joining in. And CMC will bring you more such educational packages. Please tune in. Thank you.